Have you ever stopped to think about, well, the hidden marvels working away inside your body? The organs and systems keeping everything humming along, often without any fanfare, until, well, maybe something feels a bit off.
Yeah, they're like the unsung heroes.
Exactly. Think of them like this incredibly fine-tuned plumbing network. Totally crucial, but often completely out of mind. Today on the deep dive, we're taking a plunge into one of these systems. It's intricate, surprisingly vital. Your biliary system.
Hmm.
Welcome back to the deep dive. This is where we take these complex topics, we peel back the layers, and hopefully give you those essential nuggets of knowledge maybe you didn't even know you needed. And this system, the biliary system, it's often out of sight, sure, but as you'll find out, it's definitely not out of mind when things start to go wrong.
That's for sure.
And believe me, with the biliary system, things can get, well, pretty complicated pretty quickly.
Right. So our mission today really is to unravel the intricate anatomy, the critical physiology, and then look at the common and maybe some not so common diseases that affect your biliary system.
Okay.
We're going to explore, well, everything from how your body cleverly recycles its digestive fluids, which is fascinating in itself, right up to the complexities of modern surgery that can literally save lives.
Wow.
The goal is really to give you a comprehensive understanding, but, without the information overload, just so you feel properly informed.
Perfect. So whether you're just curious about how your body works, maybe you're prepping for a medical chat, or, maybe you just love those aha moments that show the hidden genius inside us, this deep dive is definitely for you. We're going to uncover some genuinely surprising facts and really dig into the details that make this system so vital for our everyday health. All right, let's kick things off by unpacking the basic structure. So when we talk biliary system, we're basically looking at a really sophisticated network of, let's call them specialized pipes,
Yeah.
and a pretty clever storage tank, all designed specifically to move around this key digestive fluid called bile.
Yeah, and what's really fascinating here, something I always find amazing, is just the sheer anatomical variability.
Well,
We often picture human anatomy like a fixed blueprint, right?
right size fits all.
Exactly. But the biliary system really challenges that idea. Studies show that while up to 30% of people have significant anatomical variations in their bile ducts and the related structures.
30%. That's a lot.
It is.
Right.
And it's not just a biological curiosity. It has huge implications, especially for surgeons. They need to navigate this unique landscape in each patient. Understanding these differences is absolutely critical for safe surgery.
Okay, so let's trace the path. Bile starts its journey where?
It starts in these tiny ducts inside the liver, the intrahepatic ducts. They collect bile from millions of liver cells. These little ducts then merge, getting bigger, flowing into the extrahepatic ducts, which, like the name says, are outside the liver.
Got it.
And a key landmark to remember is how they're positioned. The bile ducts always run above the portal vein and sort of lateral and below the arterial supply. Picture them running side by side with the main blood vessels, like a little trio.
Okay, so a very specific layout. How do the ducts from different parts of the liver actually join up? Is it symmetrical?
Ah, good question. No, it's not always symmetrical. For instance, the left hepatic duct, it's noticeably longer than the right one.
Really?
Yeah, it has this section that runs kind of horizontally under part of the liver, segment 4, before it joins the main junction. This left duct drains segments 1, 2, 3, and 4 of the liver. It can even pick up smaller branches from segment 4 there.
Interesting. And the right duct?
The right hepatic duct is much shorter. It often splits almost right away into two main sectoral ducts. An anterior one, draining segments V and 8, and a posterior one, which drains 6 and 7.
And what about the caudate lobe? Segment 1?
Ah, the caudate lobe, segment 9, it's quite versatile. Its little ducts can actually drain into both the right and left systems.
Yeah.
Shows how interconnected it all is.
And these bigger ducts, they eventually merge into the common hepatic duct, is that right? Where the main flow starts to come together.
Exactly. The common hepatic duct forms where the left and right hepatic ducts meet, right at a spot called the Hiller plate. Think of it like a fibrous sheet extending from the liver's capsule.
Okay.
And this spot is really important surgically because usually there aren't any major blood vessels running over the ducts right there. This allows surgeons to use a technique called lowering the Hiller plate to get better exposure of the ducts, making things much safer.
Right, better access.
Then moving down, you get the common bile duct, the CBD. That forms when the cystic duct coming from the gallbladder joins the common hepatic duct. And the CBD itself has three main parts. The supraduodenal bit above the intestine, the retroduodenal part behind it, and then the pancreatic portion, which actually runs through the head of the pancreas.
Wow, right through the pancreas.
Yeah. And the whole journey ends when the CBD opens into the second part of the small intestine, the duodenum, at a place called the ampulla of Vater. Often the pancreatic duct joins right there, too, like a shared exit. But again, variations exist. Sometimes they have separate openings.
That is seriously intricate plumbing. So we've got the pipes. What about the gallbladder? We've all heard of it, maybe know someone who's had it out, but do we really get what it does beyond, sometimes causing trouble?
Yeah, it's much more than just a simple pouch. It's what we call a partially intraperitoneal organ, usually about 7 to 10 centimeters long, nestled right under the liver. And even though it's small, it's a vital reservoir. It holds about 30 to 60 milliliters of highly concentrated bile. Anatomically, it's got distinct parts. The neck, which narrows, the infundibulum, which sometimes has a little bulge called Hartmann's pouch, the main body, and then the rounded end, the fundus.
And how does it actually attach to the liver?
Good point. There's the cystic plate. It's this fibrous lining where the gallbladder sticks directly to the liver, and interestingly, it lacks that usual slippery peritoneal covering you find on most organs.
Huh.
Bile drains out through the cystic duct, connecting the gallbladder to the CBD. And this duct, its length varies a lot, maybe 1 centimeter, maybe 5. Usually it joins the CBD at a sharp angle, but, variations are the name of the game here. Sometimes it even connects directly to the right hepatic duct, which can be a big surprise during surgery.
And these valves of Heister, they sound kind of old-fashioned. Are they important?
They are. They might sound antique, but they're these subtle spiral folds inside the gallbladder neck. Their job is quite clever. They help keep the bile inside the gallbladder until it's needed, stopping it from leaking out prematurely. It's a neat bit of built-in regulation.
So this whole system, it's like an internal city with its own infrastructure.
Yeah.
And blood flow, that must be absolutely critical, right?
You hit on a really key point. Here's where it gets very interesting and, frankly, a bit risky. The entire biliary tree relies solely on arterial blood supply.
Only arterial.
Yeah.
Unlike the liver itself.
Exactly. The liver tissue, the parenchyma, gets dual perfusion blood from both the hepatic artery and the portal vein, but the bile ducts, just the artery. This makes them highly susceptible to ischemic injury. If that arterial supply gets damaged or blocked, it's bad news for the ducts.
Okay, so where does that arterial blood come from, specifically for the gallbladder?
The main supply is the cystic artery. Usually it branches off the right hepatic artery, but its origin can be all over the place.
Like where?
It might come from the left hepatic, the proper hepatic, common hepatic, gastroduodenal, even the superior mesenteric artery sometimes. And it can pass in front of or behind the common bile duct. All things a surgeon needs to be aware of.
Right.
We often find a little lymph node near it, the Callet node, useful landmark. And if it's enlarged, it can signal inflammation or even cancer.
So specific landmarks and knowing about these variations are key for safety.
Absolutely crucial. The blood supply for the common hepatic duct and the CBD mainly comes from the right hepatic and cystic arteries. Now, the right hepatic artery usually passes behind the common hepatic duct on its way to the liver. It goes through an area called the triangle of Callet.
Okay, I've heard of that triangle. Why is it so important?
It's bordered by the cystic duct, the common hepatic duct, and the liver edge. And because the right hepatic artery usually runs right through it, it's a high-risk zone during gallbladder removal, cholecystectomy, lots of vital structures packed close together, demands real precision.
Got it. High-stakes area.
And another thing surgeons need to watch for. In about 20% of people, there's an accessory or replaced right hepatic artery.
20%? Wow.
Yeah, it can sneak up along the side of the common bile duct. Identifying it beforehand, maybe on a CT scan or by feeling for a pulse during surgery, is vital to avoid injuring it.
Okay.
And lastly, the very bottom part of the bile duct gets its blood from tiny branches off the pancreaticoduodenal and gastroduodenal arteries. These form little vessels running along the CBD at the 3 and 9 o'clock positions. So dissecting too close right there risks damaging these small vessels, which could cut off blood supply and injure the duct, really underscores the delicacy needed.
Okay, so we've mapped out the incredible architecture and the vital infrastructure. Now let's talk physiology. How do we actually get this digestive fluid, bile? How is it made, moved, and released just when we need it?
Right, it all starts back in the liver in these tiny functional units called hepatic lobules. Inside these, you have the liver cells, the hepatocytes, constantly producing bile. They secrete it into microscopic channels, the bile canaliculi, the very start of the system. These tiny channels then merge, forming bigger ducts, eventually leading into the main bile ducts.
And what's actually in bile? What makes it work?
The real stars are the bile salts. They're made from cholesterol, things like cholic acid, deoxycholic acid, absolutely essential for digesting fats. But here's the really clever part, what I like to call the ultimate recycling program. Enterohepatic circulation.
Recycling. How does that work?
Your liver only produces a small fraction of the bile salts you use daily. Over 95% get recycled incredibly efficiently.
95%.
Yep. After they help digest fats in your intestine, mainly in the last part, the terminal ileum, they get reabsorbed back into your bloodstream, travel straight back to the liver attached to albumin, and boom, ready to be used again almost immediately. Less than 5% is lost in your stool each day. It's extraordinarily efficient.
That is amazing recycling. So how does the bile actually flow through these tiny ducts? It can't just be gravity, can it?
That's a good point. No, it's not just gravity. The main driving force is actually an osmotic process. Once the hepatocytes secrete bile components, tight junctions between the cells lining the ducts act like seals.
Okay.
The secretion of charged ions, along with the bile salts, creates this osmotic pull, drawing water into the ducts. This keeps the fluid concentration similar to your blood plasma and pushes the bile along. Interestingly, bile salts also form these little pockets called micelles to help dissolve cholesterol, but the micelles themselves don't really add to that osmotic push.
So besides bile salts, what else is in there?
Bile also contains proteins, phospholipids, and cholesterol. Phospholipids and cholesterol are crucial. They help your body get rid of excess cholesterol, but they also protect the liver cells and the duct lining cells from the, well, toxic detergent-like nature of bile itself.
Protect.
Exactly. And biliary secretion is a major way your body excretes cholesterol. And then you have bile pigments, mainly bilirubin. These are breakdown products from old red blood cells. They get processed in the liver, conjugated, and excreted into bile. They give bile its yellow-green color, and when gut bacteria work on them, they give stool its typical brown color.
So the liver's the factory, but the gallbladder is the master concentrator. How does it manage to concentrate bile so much, like up to tenfold?
That's its special trick. It's not just a passive bag, it's an active storage site. Its lining actively absorbs water and sodium out of the bile.
Pulls the water out.
Precisely. And that's how it concentrates the bile so dramatically, sometimes 10 times or even more.
But does that concentration cause any issues?
It can. While efficient, it significantly increases the concentration of cholesterol and calcium in the bile. This makes the cholesterol less stable, more likely to crystallize and form cholesterol gallstones. And somewhat ironically, the gallbladder also secretes glycoproteins that protect its lining, but can also promote cholesterol crystallization. So it's a delicate balance.
It really sounds like a coordinated traffic light system. When is bile actually released? It doesn't just flow constantly, does it?
No, definitely not. It's highly regulated. Neural signals, hormones, chemical cues, they all play a part. When you're fasting, there's a muscular gatekeeper at the end of the common bile duct where it enters the intestine called the sphincter of Oddi.
The gatekeeper?
Exactly. It stays tightly closed, preventing bile from flowing into the intestine. This causes bile to back up and fill the gallbladder, which can store quite a bit, maybe up to 300 milliliters of your daily production.
Okay, so what opens the gate?
Eating, basically. Especially fats and proteins. When those hit your duodenum, the intestinal lining releases a key hormone called cholecystokinin, or CCK.
CCK.
CCK is the main trigger. It causes the gallbladder to contract, forcefully generating pretty impressive pressure, up to 300 millimeter Hg, and at the same time, it tells the sphincter of Oddi to relax.
Coordinated action.
Perfectly coordinated. This allows up to 70% of the stored bile to empty into the duodenum within about 2 hours. Really efficient response to a meal.
So CCK is the main player, the master switch. Anything else involved?
Yeah, the vagus nerve, part of your autonomic nervous system, also plays a role, stimulating some bile secretion and gallbladder emptying, but it's less powerful than CCK.
No.
And the system has a built-in safety feature, too. The way the bile duct enters the duodenum at an angle, plus the fact that the sphincter stays closed during fasting, helps prevent intestinal contents bacteria, enzymes from flowing back up into the bile ducts. That's a crucial protection against infection.
This system is clearly so intricate, a real marvel. So how do doctors actually figure out what's going wrong when symptoms pop up? It must be tricky diagnosing problems in this hidden network.
It really is. It's like detective work, using a whole toolkit, and each tool has its strengths and weaknesses. We usually start with lab tests. A hepatic panel, for instance, checks liver and biliary function.
What does that show?
Well, if bilirubin and alkaline phosphatase are high, it suggests cholestasis, a problem with bile flow, often an obstruction. But if transaminases are up, it points more towards an issue with the liver cells themselves.
Okay. And bilirubin levels specifically.
Right. If you have high bilirubin, hyperbilirubinemia, it can be conjugated, meaning it's been processed by the liver but can't get out, usually suggesting obstruction. Or it can be unconjugated, pointing to problems like increased production or issues with liver uptake or processing.
And that leads to jaundice.
Exactly. Jaundice, that yellowing, becomes visible when bilirubin hits about 2.5 milligdl in the eyes or 5 milligdl in the skin. Little tip, check under the tongue, the frenulum first. Sometimes you see subtle yellowing there even before the eyes.
Good tip. So labs give clues. How do you actually see inside? I guess plain x-rays aren't much help here.
You're right, plain films, not very useful. Mostly just to rule out other things like a perforated ulcer or bowel obstruction. Gallstones rarely show up.
So if not plain films, what's the go-to imaging?
Transabdominal ultrasound. That's really the gold standard for starting the evaluation for jaundice or biliary symptoms. It's sensitive, cheap, readily available, reliable.
What makes it so good?
It's great at telling the difference between medical jaundice, like problems with red blood cell breakdown, and surgical jaundice, where there's a physical blockage stopping bile excretion, which often needs surgery.
And for gallstones?
Excellent for gallstones or cholelithiasis, high specificity and sensitivity. Stones look bright on ultrasound with a shadow behind them, and crucially, they usually move when the patient changes position, unlike polyps or sludge. Ultrasound can also spot other things, a dilated common bile duct suggesting obstruction, gallbladder wall thickening, fluid around the gallbladder hinting at cholecystitis, or even a calcified porcelain gallbladder.
What about something like a 8-dose scan? How does that fit in?
The HA-dose scan, or hepatic immunodiacetic acid scan. It doesn't give you the fine anatomical detail like ultrasound, but it's fantastic for looking at the physiology, how bile is actually flowing.
How does it work?
You inject a radioactive tracer, this immunodiacetic acid. The liver processes it and secretes it with the bile. If the gallbladder doesn't fill up with this tracer within about 2 hours, it means the cystic duct is blocked. That's diagnostic for acute cholecystitis.
Oh, okay.
Conversely, if the gallbladder does fill, it essentially rules out acute cholecystitis. HIDA can also check gallbladder function, you give CCK, and measure how much bile squirts out, the ejection fraction. Useful for diagnosing biliary dyskinesia, where people have symptoms but no stones.
Okay. What about CT scans?
CT, or computed tomography, is better for anatomic detail. Great for finding the cause and site of an obstruction, and essential for planning surgery for cancers. A triple-phase CT gives really detailed liver imaging. But many gallstones are isodents to bile, meaning they don't show up well on CT.
An MRI or MRCP.
Right, magnetic resonance imaging, and specifically MRCP, magnetic resonance cholangiopancreatography. It uses the water in bile to create detailed maps of the biliary tree in pancreas. Non-invasive, no radiation, excellent detail, especially for complex disease or suspected tumors. It basically gives you a beautiful cholangiopancreatogram.
ERCP sounds more involved, more invasive.
Yeah.
But it seems like it can do more than just take pictures.
It absolutely can, and that's its big advantage. ERCP, endoscopic retrograde cholangiopancreatography, is invasive. It uses an endoscope down into the duodenum and a small catheter into the bile duct opening to inject contrast under X-ray guidance.
Okay.
It does have a complication rate, maybe up to 10%, things like pancreatitis. But its strength is that it's both diagnostic and therapeutic. You can remove stones, put in stents to relieve blockages, take biopsies. Really useful for malignant obstructions or post-surgical problems.
What if ERCP isn't possible?
Then there's PTC, or percutaneous transhepatic cholangiography, also invasive. Interventional radiologists use a needle directly through the skin into the liver to access the bile ducts. Allows for imaging, drainage, biopsies, especially if ERCP fails or for disease mainly inside the liver.
And during surgery itself, IOC.
Intraoperative cholangiography, yeah. A catheter is put into the cystic duct during surgery to image the ducts in real time. Helps map anatomy, find hidden CBD stones, guide reconstruction.
Is it used routinely?
That's debated. Routine use adds time, radiation, doesn't drastically cut injury rates, and can be misinterpreted, but it's widely used selectively if the anatomy is unclear, if there's trouble identifying things, suspected injury, unexplained pain, or suspicion of CBD stones.
Okay. Any other imaging tools?
A couple more. Endoscopic ultrasound, or EUS, limited for the gallbladder itself, but very valuable for the lower end of the common bile duct and the ampulla. Great detail for checking tumor invasion into blood vessels or guiding biopsies there.
And PT scans.
FDG PET scans exploit metabolic differences. Cancer cells are often highly active, gobbling up glucose. So you inject a radio-labeled glucose, and the PET scan lights up active areas. Helps tell benign from malignant, finds recurrence or metastases. Its main limitation is that inflammation and infection are also metabolically active, so you can get false positives.
It's kind of surprising, isn't it, that this internal system isn't actually sterile? You'd think it would be cleaner.
Yeah, that's a common thought, but it makes sense when you think about it. The biliary tree connects directly to the duodenum, the first part of the small intestine, and that's definitely not sterile.
Right, lots of bacteria there.
Exactly.
Yeah.
So the biliary system isn't truly sterile, but normally the bacterial load is low and the constant flow of bile washes things out, so infection is rare. However, if you have stones or any kind of obstruction, that changes everything.
How so?
When bile flow stops or slows down, bacteria have a chance to multiply. Stagnant bile is a great breeding ground. That's when you get infections like cholecystitis or cholangitis.
What kind of bacteria usually cause trouble?
Mostly gut bacteria, things from the Enterobacteriaceae family like E. coli, Klebsiella, and Enterobacter. Also Enterococcus species.
So antibiotics are important then.
Definitely. Prophylactic antibiotics given beforehand are often used for procedures like ERCP or PTC to prevent infection. And if an infection is suspected or confirmed, like in acute cholecystitis or ascending cholangitis, broad-spectrum antibiotics targeting these common bacteria are absolutely necessary.
Okay, let's dive into probably the most common issue people have with their biliary system. Gallstones. Sounds simple, but I gather it's more complex than just little pebbles forming.
You got it. Cholelithiasis, having gallstones, is incredibly common, affects maybe 10–15% of people, and they're not all the same. We mainly talk about two types based on what they're made of, cholesterol stones and pigment stones.
Cholesterol stones sound self-explanatory.
Mostly. In the U.S., they make up over 70% of gallstones. Formed from precipitation of cholesterol and calcium, pure cholesterol stones are actually pretty rare, less than 10%.
Okay, and pigment stones.
Less common, but important. Two subtypes here. Black stones, often linked to conditions where red blood cells break down a lot, like hemolytic anemias or liver cirrhosis. They're almost always found just in the gallbladder. Then you have brown stones.
Brown stones.
Yeah, these tend to form in the bile ducts themselves, often linked to infection, and they incorporate some cholesterol too, more common in Asian populations. The color difference is basically down to how much cholesterol is mixed in.
So how do these stones actually form? Is there like a recipe for gallstones?
Sort of. There are four main factors, sometimes called the four horsemen of stone formation. First, supersaturation of bile. Meaning your liver is putting out bile with too much cholesterol in it for cholesterol stones, or too many breakdown products for pigment stones. The bile just can't hold it all dissolved.
Okay, factor one. What's next?
Second is concentration of bile in the gallbladder. As we said, the gallbladder sucks out water and sodium, making everything else, including cholesterol and calcium, much more concentrated, easier for crystals to form.
Makes sense.
Third, crystal nucleation. This is the actual starting point where tiny crystals begin to form. Certain things in bile, like glycoproteins or immunoglobulins, can act as accelerators, pronucleating agents.
And the fourth horseman.
Gallbladder dysmotility. If the gallbladder isn't squeezing and emptying properly, bile sits around, it gets stagnant. Stasis allows more time for stuff to precipitate out and for those tiny crystals to grow into actual stones. We see this with prolonged fasting, IV nutrition, certain nerve damage.
Right, but lots of people have gallstones and feel fine, don't they? They're just found by accident.
Absolutely. Most are found, incidentally. And the vast majority, maybe 70–80% of people with asymptomatic stones will never develop symptoms.
So you don't usually take out the gallbladder just because stones are there?
Generally, no. Prophylactic cholecystectomy isn't usually warranted for asymptomatic stones. The risk of complications from the stones themselves is quite low, about 1% per year, often lower than the risks of surgery.
But are there exceptions? Times when you would take it out even without symptoms?
Yes, there are specific high-risk groups where we do consider it. People with hemolytic anemias like sickle cell, they form pigment stones frequently and have higher complication rates. Patients with a porcelain gallbladder where the wall is calcified or very large stones, say over 2.5 centimeters, have a slightly higher cancer risk.
Okay.
Also, certain anatomical variations, like a long common channel between the bile and pancreatic ducts. And patients having bariatric surgery, rapid weight loss promotes stones, and ERCP becomes difficult after bypass. Also, sometimes diabetic patients, as they can get more severe infections if cholecystitis develops.
So if you do have symptoms, what about non-surgical treatments? Can you dissolve stones or blast them?
Those options exist, but honestly, they're rarely successful or practical now. Oral bile salt pills to dissolve cholesterol stones, directly infusing solvents, shockwave lithotripsy to break them up.
Why aren't they used much?
High recurrence rates are the big problem. Stones often come back up to 50% of the time within 5 years for dissolution therapies. Lithotripsy is only suitable for very specific cases, like a single small stone. With laparoscopic cholecystectomy being so safe and effective now, these non-operative treatments are really just niche options for people who absolutely can't have surgery.
Okay, so what's the difference between just having gallstone pain, biliary colic, and having chronic cholecystitis? Is it a progression?
It often is. Chronic cholecystitis usually comes from repeated attacks of biliary colic. That's when a stone temporarily blocks the cystic duct, causing pain but then moves. These recurrent episodes lead to ongoing inflammation, scarring, and fibrosis, especially around the gallbladder, neck, and cystic duct.
How does that present?
As symptomatic cholelithiasis or biliary colic, the pain is often constant, maybe lasting a few hours, not really colicky like waves of pain, usually in the upper abdomen, maybe radiating to the shoulder blade.
Is it always after fatty food?
Only about half the time, actually. But if the pain lasts more than 24 hours or you get a fever, that suggests it's progressed to acute cholecystitis, which is more serious. You might also get bloating, nausea, vomiting. Diagnosis relies on the history and ultrasound showing stones or sludge.
And the treatment for chronic cholecystitis?
Elective cholecystectomy. If the symptoms are bothersome enough, for mild symptoms, maybe observation is okay, but for more frequent or severe pain, the complication rate without surgery is higher, around 7% per year. Laparoscopic removal is curative for over 90% of people.
So when does it tip over into acute? What makes it an emergency?
Acute cholecystitis happens when that blockage of the cystic duct by a stone isn't temporary, it's sustained. The stone gets stuck.
Okay.
Bile can't get out at all. This leads to progressive inflammation, swelling, even bleeding in the gallbladder wall. Then, the trapped bile often gets infected by bacteria.
What can happen then?
It can get really bad. The
Yeah.
wall can lose blood supply, become ischemic, necrotic, die off. That's gangrenous cholecystitis. In rare, severe cases with gas-forming bacteria, you get emphysematous cholecystitis, which is life-threatening.
How do patients present with acute cholecystitis?
Typically fever, intense right upper quadrant pain, tenderness, guarding where the muscles tense up. A classic sign is the Murphy sign. You press under the right ribs, ask the patient to breathe in, and they stop abruptly because of pain.
Right.
Significant jaundice is rare unless there's another issue like Murizi syndrome, where the inflamed gallbladder presses on the common hepatic duct. There are grading systems, like the Tokyo guidelines, to assess severity and guide treatment urgency.
And diagnosis? Still ultrasound?
Ultrasound is usually the first step, and very good shows stones, fluid around the gallbladder, thick wall, maybe that sonographic Murphy sign. If it's unclear, a HIDA scan is definitive if the gallbladder doesn't light up, the cystic duct is blocked.
Yep.
Immediate 4V fluids, broad-spectrum antibiotics, and then cholecystectomy is the definitive treatment. The timing used to be debated, operate early or wait weeks. But now, evidence strongly supports early surgery, usually within the first week. Outcomes are as good or better, and fewer people fail non-operative management.
What if someone is too sick for surgery right away?
That's where a percutaneous cholecystostomy tube comes in. A drain placed directly into the gallbladder under imaging guidance. It drains the infected bile, cools things down, stabilizes the patient, allowing for surgery later when they're stronger, works well in over 90% of those cases.
Now, what if a stone escapes the gallbladder and goes down the main pipe, the common bile duct? That sounds like it could cause bigger problems.
It absolutely can. That's choledocholithiasis, common bile duct stones. Interestingly, they're often silent, found by accident in maybe 10% of people having imaging.
Where do they come from?
They can be primary forming in the bile duct itself, often brown pigment stones linked to infection, more common in Asia, Or, more often in the West, they're secondary. They passed from the gallbladder into the common duct.
What symptoms do they cause?
Can range from that biliary colic pain to full-on obstructive jaundice, dark urine, yellow eyes, pale stools. The jaundice is usually painful because the blockage is sudden, stretching the duct quickly.
And the most dangerous complication?
Cholangitis, an ascending bacterial infection of the common bile duct, happens because the blockage raises pressure, letting bacteria climb up from the intestine.
Is that the Charcot's triad thing?
Right. Charcot's triad is right upper quadrant pain, fever, and jaundice. But less than half of patients actually have all three. If it progresses to Reynolds pentad, the triad, plus septic shock signs like confusion and low blood pressure, that's incredibly serious, near 100% mortality without urgent treatment.
How are CBD stones diagnosed and treated?
Ultrasound might show a dilated duct over 8 millimeter. MRCP is great for diagnosis, very sensitive. But ERCP is often the go-to because it's diagnostic and therapeutic. You can do a sphincterotomy, cut the muscle at the end of the duct, and pull the stones out. Very effective.
Oh.
If ERCP fails or isn't possible, maybe because of previous surgery, PTC can be used. Or surgeons can do a common bile duct exploration, either laparoscopically or open. And usually once the duct is cleared, the gallbladder comes out too to stop it happening again.
And stones can mess with the pancreas too. Gallstone pancreatitis.
Yes, another serious issue. If a stone passes through that shared opening, the ampulla, it can injure the pancreas or temporarily block the pancreatic duct, causing inflammation, pancreatitis.
How's that treated?
Usually the pancreatitis settles once the stone passes. Early ERCP might be needed to remove an impacted stone. And definitely cholecystectomy is needed to prevent recurrence, often done during the same hospital stay.
Okay, this next one sounds bizarre. Gallstone ileus. A gallstone causing a bowel obstruction.
Yeah, it's a strange one, and ileus is a bit of a misnomer. It's a mechanical blockage, not paralyzed bowel. What happens is a really large gallstone, usually over 2.5 centimeters, erodes directly from the gallbladder into the adjacent duodenum, creating a fistula, a direct connection.
Wow.
The stone then travels down the intestine and gets stuck, usually in the narrowest part, the terminal ileum, causing a small bowel obstruction.
Gets us.
Typically elderly patients, often with a history of gallstone issues, presenting with sudden obstruction symptoms. Plain x-rays might show the obstruction, and sometimes pneumobilia error in the bile ducts because of that fistula. CT confirms it.
And the fix.
Surgery. You have to go in and remove the stone from the ileum. Sometimes surgeons try to fix the fistula and remove the gallbladder at the same time, but often, especially in frail patients, just removing the stone is the main goal due to the inflammation and risks.
So what if there are no stones, no obvious blockage, but still biliary problems? Can the system just malfunction?
Absolutely. That brings us to non-calculous biliary diseases. Things can definitely go wrong without a physical blockage.
Like what?
A prime example is acute acalculous cholecystitis, inflammation of the gallbladder, but no stones blocking the cystic duct.
What causes that then?
The exact cause isn't totally clear, but bile stasis, bile not moving, and ischemia, lack of blood flow to the gallbladder wall, seem to be key factors. We often see it in really sick patients, burn victims, trauma patients, people on long-term IV nutrition, the critically ill, immunosuppressed diabetics.
How does it present?
Similar to regular acute cholecystitis, sometimes even worse, but in critically ill patients, they might not have the typical pain. A fever with no clear source, plus gallbladder wall thickening or fluid on imaging, should make you suspicious.
Diagnosis.
HID is usually diagnostic, showing the cystic duct is functionally blocked, but false positives can happen.
Treatment.
Cholecystectomy is curative, but often these patients are too unstable. So again, that percutaneous cholecystostomy tube draining the gallbladder is often the safer first step.
What about biliary dyskinesia?
This is a functional problem. The gallbladder just doesn't squeeze properly. Patients have all the classic symptoms of gallstones, pain, nausea, but ultrasound is completely clear. No stones, no sludge.
So how do you diagnose it?
Often a diagnosis of exclusion, ruling other things out first. A CCK HIDA scan showing poor emptying and ejection fraction less than about a third is considered diagnostic.
Does taking the gallbladder out help?
Yes, surprisingly often. Over 85% of patients get significant symptom relief after cholecystectomy.
And sphincter of Oddi dysfunction. You mentioned the gatekeeper before. This is when it doesn't open right.
Precisely. The sphincter of Oddi muscle is too tight or fails to relax when it should. Causes pain, sometimes recurrent pancreatitis, even with normal liver tests. Can happen after pancreatitis or gallstone issues cause scarring.
How's that diagnosed and treated?
You suspect it with biliary pain and a wide bile duct, maybe over 12 millimeter. Measuring the pressure directly with sphincter manometry can predict who will respond well to treatment. Treatment is usually cutting the sphincter muscle, either endoscopically, sphincterotomy, or sometimes surgically, sphincteroplasty. Gives relief in 60–80% of cases.
Then there's primary sclerosing cholangitis, PSC. That sounds pretty serious and progressive.
It is. It's an autoimmune disease causing inflammation and scarring, fibrosis of the bile ducts, both inside and outside the liver.
And it's linked to other conditions.
Strongly linked to ulcerative colitis. Nearly 70% of PSC patients have UC. It leads to chronic cholestasis, biliary cirrhosis, and eventually liver failure.
Symptoms.
Often fatigue, intense itching, pruritus, or it's picked up on abnormal liver tests. Imaging, like MRCP, shows this characteristic beading or chain of lakes pattern areas of narrowing, alternating with dilation in the ducts.
Treatment options.
Ursodeoxycholic acid is used, but whether it slows the disease is debatable. Endoscopic balloon dilation of dominant strictures can help symptoms, reduce infections, maybe prolong survival. But ultimately, for progressive liver failure, liver transplantation is the only cure. And unfortunately, a PSC can sometimes recur, even in the new liver.
What about simple biliary strictures? Just narrowings?
Yeah, narrowing anywhere in the ducts can be caused by previous infections, lack of blood flow, inflammation. Chronic pancreatitis often causes long, tapered strictures in the lower CBD. But the most common iatrogenic cause, meaning caused by medical treatment, is injury during cholecystectomy. Happens in maybe 0.11% of cases. Maridzi syndrome, that stone compressing the duct, is another cause.
How are strictures treated?
Usually ERCP, first sphincterotomy, balloon dilation, putting in stents. Often successful long-term in over half of cases. If that fails, surgery to bypass the stricture, usually a Roux-en-Y hepatocholecystectomy, is highly effective, over 90% success.
And biliary cysts, or coloidal cysts. You mentioned they're congenital.
Right. Now often called biliary malformations. They're rare dilations of the bile ducts present from birth, more common in females, Asians, and importantly, they're considered pre-malignant.
Pre-malignant, a birth defect leading to cancer risk later. That's quite a spectrum.
It is. The lifetime risk of cancer, mainly cholangiocarcinoma, is significant, 5–30%, especially in types I and IV cysts. Type I, a fusiform dilation of the extrahepatic duct, is the most common.
What causes them?
For types I and V, it's often an anomalous pancreatobiliary junction, APBJ. The pancreatic and bile ducts join outside the duodenum, allowing pancreatic enzymes to reflux into the bile duct, causing chronic inflammation, damage, and eventually cystic changes and cancer risk.
Presentation and treatment.
Usually jaundice, pain, maybe a mass, diagnosed with imaging like CT, classified with MRCP or CP. Treatment is complete surgical excision of the cyst, removing the gallbladder and creating a Roux-en-Y bypass for type I to eliminate the cancer risk.
What about gallbladder polyps? Are they common? Worrisome.
Very common, found in maybe 3–12% of people. Most are pseudopolyps, cholesterol deposits, inflammatory changes, not true growths. Only about 5% are true polyps.
Do they turn cancerous?
Adenomatous polyps can. The risk factors for malignancy are a single polyp, size over 1 centimeter, and patient age over 50. So cholecystectomy is generally recommended for polyps over 1 centimeter. Smaller ones are usually watched with ultrasound unless there are other risk factors like PSC.
And finally, benign biliary masses.
These can be precursors to malignancy, like intraepithelial lesions or things like intraductal papillary neoplasm, some of which are premalignant. They usually cause obstruction, pain, jaundice. Treatment is complete resection. Sometimes inflammatory masses, pseudotumors can mimic cancer, making diagnosis tricky.
Okay, we've covered a lot of things that can go wrong.
Yeah.
Thankfully, modern medicine has some amazing ways to fix them. Laparoscopic cholecystectomy that really changed the game for gallbladder surgery, didn't it?
Oh, absolutely. A true revolution. First done in the mid-'80s, now it's one of the most common general surgery procedures globally.
What are the big advantages?
Smaller incisions, much less pain afterwards, way shorter hospital stays compared to the old open surgery. It's usually done for simple biliary colic, but it can be done safely for acute inflammation too, although it might be tougher, take longer, higher chance of needing to convert to open, maybe slightly higher risk of CBD injury in acute settings.
Are there times you can't do it laparoscopically?
Yeah, main contraindications are things like inability to tolerate general anesthesia, severe end-stage liver disease with portal hypertension, major clotting problems, or really severe heart or lung disease, often relative contraindications judged case by case.
Can you walk us through the basics of the procedure, the 4-port technique?
Sure, it's quite elegant. Really, usually one slightly larger incision near the belly button for the camera and eventually removing the gallbladder. Then 3 smaller, maybe 5 mm incisions elsewhere in the upper abdomen. Carbon dioxide gas is used to inflate the abdomen, create space. Then instruments go through the small ports. One lifts the top of the gallbladder up, exposing where it attaches. Another grabs the lower part, the infundibulum, and pulls it kind of down and sideways.
And this is where that critical view of safety comes in. Sounds crucial.
It is paramount for avoiding bile duct injury. That specific downward and outward traction aims to achieve this critical view. The goal is to clearly see only 2 structures entering the gallbladder base, the cystic duct and the cystic artery. And importantly, you need to see the liver bed behind these structures.
Why is that view so critical?
It helps separate the cystic duct from the common hepatic duct. Without it, they can look like they're running parallel, and it's easy to mistake the common duct for the cystic duct and clip or cut the wrong one. A classic error trap.
Got it. So once that view is achieved.
The surgeon carefully dissects the fatty tissue and Cowlitz triangle to clearly identify the cystic duct and artery. Clips are placed on both, usually 2 clips on the common duct side of the cystic duct for security, and then they're cut.
What about checking the ducts with X-ray during surgery? IOC.
Intraoperative cholangiogram. If that's done, the duct is clipped only on the gallbladder side first. A small cut is made, catheter inserted, contrast injected for the X-ray. If the IOC is normal, or if none is done, the duct gets fully clipped and cut. Then the cystic artery is cut. Finally, the gallbladder is peeled off the liver bed using an energy device controlling any bleeding. Then it's pulled out, often in a bag, especially if it was inflamed or perforated, and any spilled stones are retrieved.
You mentioned the debate about IOC routine versus selective.
Yeah, it's ongoing. Routine IOC finds unexpected stones in only a small percentage, doesn't clearly reduce overall injury rates, and can be misinterpreted, but it can identify an injury the moment it happens.
But when is it definitely useful?
Selectively, yes. If the anatomy looks weird, if identification is difficult, if an injury is suspected, unexplained pain, strong suspicion of CBD stones not cleared pre-op, abnormal liver tests, dilated CBD on imaging. Laparoscopic ultrasound is an alternative for checking for stones, but it's very operator dependent.
What if the laparoscopic approach just gets too dangerous or difficult during the operation? Are there backup plans, bailout procedures?
Yes, absolutely critical, especially with severe inflammation or tricky anatomy. Surgeons need these escape routes. One is a subtotal cholecystectomy, removing most of the gallbladder but leaving a small part attached to the liver, either sewing it closed or leaving it open to drain.
Okay.
Another is the fundus first technique, or retrograde dissection. You start peeling the gallbladder off the liver from the top down without tackling the duct and artery first. Can end up being subtotal or complete. And ultimately, converting to a traditional open operation is always a safe fallback if laparoscopy becomes too risky. Open cholecystectomy, while less common now, is still vital. Used for conversions if laparoscopy is contraindicated, or as part of bigger operations like a Whipple, usually done through a midline or right subcostal incision. Can be challenging with severe inflammation, especially identifying the artery early.
And if stones are known to be in the common bile duct, how are they removed during an open surgery?
That's open common bile duct exploration. Surgeon might feel for the stone, try to milk it back up, then make an incision in the CBD, called a cholecystectomy, usually above the duodenum.
And then
Flush the duct, use special balloon catheters or baskets, maybe under X-ray guidance, to retrieve the stones. A flexible scope, a choledocoscope, can be used to look inside the duct. Afterwards, often a T-shaped tube, a T-tube, is placed in the duct temporarily for drainage, and a final X-ray confirms it's clear.
Are there other options for complex CBD stone situations during open surgery?
Yes, if the duct is very dilated or stones are impacted low down, or there are strictures or stones formed in the duct, drainage procedures are often needed, either connecting the CBD directly to the duodenum, choledoduodenostomy, or to a loop of jejunum, root-en-way hepaticojejunostomy.
Pros and cons.
Choledochoduodenostomy allows future endoscopy, but risks sump syndrome debris collecting in the bypassed lower duct. Root-en-or gives great drainage, no sump risk, but blocks future endoscopic access. For stones stuck right at the ampulla, a transduodenal sphincteroplasty might be done, cutting the sphincter muscle directly through an incision in the duodenum. Open exploration is generally safe, low complication rates.
Can this CBD exploration also be done laparoscopically, minimally invasively?
Yes, definitely. 2 main ways, transcystic or via cholecystectomy.
Transcystic. through the cystic duct.
Exactly. Pass a small flexible scope through the cystic duct, maybe after dilating it gently, into the common duct. Use a basket to grab the stone. Often avoids needing a T-tube, technically simpler sometimes.
When wouldn't that work?
If there are lots of stones, really big stones, over 1 centimeter, stones up in the liver ducts, or if the cystic duct just won't dilate enough.
So the alternative is?
Laparoscopic cholecystectomy, making a small cut directly into the common bile duct laparoscopically. Insert the scope, remove stones, then usually place a T-tube and suture the duct closed around it.
How successful are these lap CBD explorations?
Pretty good, 75–95% stone clearance. Outcomes are similar to doing lap col followed by a separate ERCP later, but doing it all in one go, laparoscopically, often means shorter hospital stays and potentially lower costs. A real advance.
So, the surgery's done, but what happens if symptoms hang around or even come back after the gallbladder is out? That must be frustrating.
It definitely can be. That's what we call post-cholecystectomy syndrome, or PCS. Happens in maybe 10–15% of patients, sometimes soon after surgery, sometimes years later. More common in women.
And the symptoms are similar to before surgery.
Often, yes. Upper abdominal pain, indigestion, maybe even jaundice. The tricky part is figuring out why.
What causes PCS?
It's a mix. Could be related to the surgery itself. Maybe a stone was left behind in the common bile duct, or there's a small bile leak, or a long piece of the cystic duct was left and is causing issues. Or it could be something completely unrelated that was maybe missed before or developed later: reflex, esophagitis, even sphincter of Oddi dysfunction. Needs careful investigation.
Okay, now for the big one. Bile duct injury. Sounds like a surgeon's worst nightmare.
It truly is one of the most serious complications. And worryingly, over 80% of bile duct injuries happen during cholecystectomy, that very common operation.
What increases the risk?
Several things. Tricky anatomy variations, severe inflammation, making things unclear, poor surgical technique or exposure, maybe lack of experience, or trying too hard to stop bleeding aggressively. But often, the root cause isn't just skill, it's misperception of the anatomy. Mistaking one struppeter for another.
How does that happen?
Like we discussed with the critical view, if you don't get that proper traction, the common hepatic duct can look like it's running parallel to the cystic duct. Easy to clip or cut the wrong one if you misidentify it. Confirmation bias can play a role too, seeing what you expect to see. This is why many injuries aren't even recognized during the surgery.
How are injuries classified?
The Strasberg classification is commonly used. It categorizes them based on location and type leaks versus strictures, which helps guide how to repair them. Injuries can cause bile leakage, which usually shows up early with pain, fever, maybe bile draining. Or they can cause strictures, narrowings, which lead to jaundice and pain, often showing up months later.
If an injury is spotted during the operation, what's done immediately?
Crucial time. Usually convert to open surgery for a better view, do an IOC x-ray to see the full extent. The goals are to save as much healthy duct as possible, stop any leak, and make a tension-free repair.
How will it be repaired?
Depends on the injury. Minor cuts, less than half the circumference, not from cautery, in a decent-sized duct. Maybe just placing a T-tube through the injury site works, but for major injuries, more than half the circumference or a big defect. You have to resect the damaged part and reconnect the healthy duct end to the intestine, usually with that Roux-en-Y jejunal loop. Mobilizing the duodenum, a Kocher maneuver, is key to avoid tension.
What else needs checking?
Always check for associated blood vessel injuries. Hepatic artery or portal vein common in maybe 20% or more cases. Use Doppler ultrasound. And critically, if there isn't a surgeon experienced in biliary reconstruction right there, the best thing is to place drains to control leakage and immediately refer the patient to a specialized center. Early expert repair is key for good long-term outcomes.
And if the injury is missed and found later, weeks or months after?
That's a different challenge. 3 critical goals then. First, control infection and inflammation. Antibiotics, drain any collections, myelomas. Decompress the biliary tree with the drains. No rush for immediate repair here. Waiting for inflammation to settle, often weeks, actually improves outcomes.
Okay, control the infection first. Then what?
Second, clearly map the anatomy. You need cholangiography, MRCP, PTC, ERCP, often combined to see exactly where the injury is and what healthy ducts remain. Can't fix it if you don't know the map. Small leaks, like from the cystic duct stump, might even heal with just ERCP stenting.
And the third goal?
Re-establish durable drainage. While sometimes balloon dilation via PTC works, surgical reconstruction, usually that Roux-en-Y hepatocogegnostomy, gives the best long-term results. Needs a meticulous, tension-free, mucosa-to-mucosa connection. If the injury is high up near the bifurcation, long-term internal stents might help keep it open. But with early recognition and expert referral, outcomes are generally very good, over 90% success.
So a simple bile leak, not a major injury, is maybe more common and less severe.
Generally, yes. Often from the cystic duct stump where the clip came off, or maybe a tiny accessory duct of Luschka, wasn't sealed. Higher risk after acute cholecystitis because inflammation resolves and clips can dislodge.
Presentation.
Usually within a week, fever, chills, pain, maybe jaundice, bile leaking from wound or drain, feeling unwell.
Diagnosis and treatment.
CT might show fluid or a collection, biloma. ERCP confirms the leak site. For most cystic duct leaks, after draining any collection and starting antibiotics, ERCP with sphincterotomy and placing a stent in the common duct is usually enough. It diverts bile flow, allowing the leak to seal on its own without more surgery.
Can gallstones actually get lost inside the abdomen during surgery?
Sounds strange, but yes. The gallbladder can tear during removal, spilling stones. Happens in maybe 20–40% of lap cols.
What increases the risk?
Fragile gallbladder wall from inflammation, pigmented stones, lots of stones, maybe less surgeon experience.
Is it serious?
It can be. Consequences might not show up for months or years. Chronic abscesses, fistulas, infections, even bowel obstruction if a big stone is left.
Yeah.
They often settle near the liver.
What's done if stones spill?
Doesn't usually require converting to open. Lots of washing out, try to retrieve them, antibiotics, document it carefully. And importantly, tell the patient there's a small chance of late problems. What about retained stones? Stones left in the common bile duct.
Ah, so they were there before surgery but missed.
Exactly. Or maybe passed from the gallbladder during the operation, usually cause symptoms within weeks, but up to 2 years later. Jaundice, high alkaline phosphatase, pain. Ultrasound might not show duct dilation initially.
Treatment.
ERCP with sphincterotomy and stone removal is almost always successful.
And acute cholangitis again, that infection. Can that happen post-op too?
Yes. Any obstruction after surgery, a retained stone, a stricture, even a surgical clip migrating can block bile flow and lead to that ascending bacterial infection. Same culprits, E. coli, Klebsiella, etc.
Presentation and treatment still the same.
Pretty much. Charcot's triad, maybe, maybe not. High white count, abnormal liver tests, ultrasound, CT, help diagnose. ERCP-TTC are diagnostic and therapeutic. Treatment is IV fluids, antibiotics, and urgent biliary decompression endoscopically or percutaneously usually. Surgery if those fail. Finally, there's recurrent pyogenic cholangitis, RPC, more common in East Asia, linked to chronic infection, often with parasites like liver flukes, leading to brown pigment stones forming within the liver ducts.
So recurrent infections and stones inside the liver.
Right. Causes repeated bouts of cholangitis, liver abscesses, cirrhosis eventually. Also a risk factor for cholangiocarcinoma. Presents usually in younger adults, 30s, 40s, with cholangitis symptoms. CTM-RCP-ECP, diagnose it. Treatment involves antibiotics for acute attacks, but definitive treatment is usually surgery. Remove all stones, bypass or resect strictures, ensure good drainage, sometimes even liver resection if it's confined to one side.
Okay, we've moved from stones and functional issues to something far more serious.
Yeah.
Malignant biliary diseases. Gallbladder cancer, specifically, often has a very poor prognosis, doesn't it? A stark contrast.
It really is. It's an aggressive cancer and, tragically, often found late because early symptoms are so vague, easily missed or blamed on other things. That late presentation is why the outlook is often so grim.
Who typically gets it?
Usually people in their 60s and 70s, 2 to 3 times more common in women. Highest rates are seen in women from India, Pakistan, Native Americans, Latin American immigrants. It's the most common biliary tract cancer in the U.S.
What causes it? Is it just bad luck?
The leading theory is chronic inflammation triggering cancerous changes. So gallstones are the biggest risk factor. Over 80% of patients have them, especially large stones over 3 centimeters.
Other risks?
Things causing chronic irritation, that anomalous pancreaticobiliary junction, choledochal cysts, PSC, porcelain gallbladder, though that risk is lower than once thought, 10%.
Sure.
Also, benign adenoma polyps can potentially progress to cancer, especially if they're single over 1 centimeter in older patients.
How does spread?
Aggressively, through lymph nodes, bloodstream, across the abdomen, peritoneal spread, even along biopsy tracts or wound sites. Pathologically, usually adenocarcinoma. Can be infiltrative, nodular, or papillary, which is a slightly better prognosis. Lymph drainage is extensive, and the thin gallbladder wall means it invades the liver early, often segment AV directly.
Clinical presentation, how does it show up?
Most start in the fundus, or body, so symptoms are often late. Sadly, many present with advanced disease, 35% nodal spread, 40% distant mets at diagnosis.
Any earlier signs?
Paradoxically, sometimes symptoms of acute cholecystitis, if the tumor blocks the neck, can lead to earlier diagnosis and potentially better outcome. Late signs are weight loss, jaundice, maybe a palpable mass, or just chronic upper abdominal pain, feeling full quickly.
Diagnosis must be tough then.
Very. Labs aren't usually helpful early on. Tumor markers like CEA, CA19-9 aren't reliable for diagnosis, more for monitoring. Ultrasound might show an irregular mass or a thick wall. A polyp 1 centimeter is suspicious. CT and MRI are crucial for staging, checking local invasions, spread to liver, nodes, blood vessels. MRCP maps the ducts. Peak scans for METs. Biopsy is generally avoided if resection seems possible due to seeding risk, only done for unresectable disease to confirm diagnosis for palliative care.
Treatment. Is cure possible?
Resection surgery is the only potential cure. Patients fall into groups, found as a polyp, found incidentally after cholecystectomy, suspected beforehand, or clearly advanced disease.
How is treatment decided based on that?
For polyps, 1 centimeter cholecystectomy. If found incidentally after surgery, if it's T1A, just the inner lining, the initial cholecystectomy is often enough, cure rates are high. But for T1B, into muscle or deeper, an extended cholecystectomy is usually recommended if the patient is fit.
What does extended cholecystectomy involve more than just the gallbladder?
Yes, it's a bigger operation aiming for clear margins. R0 resection includes removing regional lymph nodes and taking a 2 centimeter margin of liver tissue around where the gallbladder sat, often parts of segments 5E and V. Maybe port site excision too? If suspected pre-op and deemed resectable, diagnostic laparoscopy first to rule out hidden METs, then attempt resection. For T3, T4 cancers invading further, it might mean major liver resection.
And for advanced disease?
Palliation, manage symptoms. Jaundice needs stenting, usually metal stents. Pain control, maybe duodenal stenting for obstruction. Sadly, chemo and radiation haven't shown a clear survival benefit as primary treatments.
Is adjuvant therapy used after surgery?
Often considered for high-risk cases, T4, positive nodes, positive margins, R1, usually gemcitabine-based chemo, maybe with platinum. But survival really depends on stage and achieving that R0 resection. T1A good, T1B good if margins clear. T2 depends on nodes. T3 survival poor, T4 METs very poor, measured in months. Overall, 5-year survival is tragically low, less than 15%.
A really tough one. And bile duct cancer, cholangiocarcinoma, also often a silent killer.
Yes, another rare but devastating cancer with a poor prognosis, and its incidence is rising. Second most common, primary liver cancer. Can be parietal, near the junction, Klatskin tumors, most common. Intrahepatic, within liver, or distal, lower down.
Risk factors similar, chronic inflammation.
Often, yes. Colodocal cysts carry a big risk if not removed. Litter fluke infections in Southeast Asia. Recurrent pyogenic cholangitis. But in the West, the most common risk factor is PSC.
That autoimmune condition again.
Right. Cumulative annual risk of 1.5% in PSC patients, may be higher with IBD, can be multifocal. Other risks include chemicals, smoking, and cirrhosis is a significant risk factor too.
Staging and presentation.
TNM staging, but different systems for intrahepatic, parahilar, distal, pathologically sclerosing, nodular, or papillary, distal better prognosis. R0 resection and node status are key. Presentation, often painless jaundice, can cause one lobe of the liver to shrink, the other to grow, delaying diagnosis. Itching, dark urine, pale stools are common. Pain often means advanced disease due to nerve invasion.
Diagnosis and assessing resectability.
Labs show obstructive jaundice, tumor markers unreliable for diagnosis. Ultrasound might show dilated ducts. CT MRI are crucial for staging, checking vascular involvement, METs. Telangiography, MRCC, PTC, ERCP maps the extent. There are clear criteria for unresectability bilateral disease, main vessel encasement. Tissue diagnosis isn't always needed pre-op if resection looks feasible. Pre-op drainage might help very jaundiced patients.
Treatment. Again, surgery is the only hope for cure.
Yes. Operative management is the only potential cure. Often explore even without definite tissue proof, as some suspected cases turn out benign. Staging laparoscopy first to avoid futile major surgery.
What kind of surgery?
For distal tumors, it's a Whipple procedure, pancreatic duodenectomy. R0 resection is critical. For proximal Klatskin tumors, it's complex. Resect the CBD, nodes, often part of the liver, including caudate lobe, to get clear margins. May involve vascular reconstruction. More extensive liver resection improves survival. Negative margins are key.
Adjuvant therapy.
Similar story to gallbladder cancer. No consistent proven survival benefit from chemoradiation afterwards, but used selectively for high-risk features or in trials.
Palliation for unresectable disease.
Yes. Relieve jaundice with stents, metal preferred. Pain control, maybe duodenal stenting.
Outcomes.
Highly dependent on stage R0 resection. 5-year survival, 20–45% for resected cases. Node mets are bad news. Median survival for unresected is just 5–8 months. Transplantation with chemoradiation is experimental, but shows some promise in very select cases. And briefly, other tumors can affect the system too. Compression from nodal mets from other cancers, liver, pancreas, colon, or lymphoma, can block the CVD. Rarely, tumors like HCC can grow into the bile ducts. And cystic tumors in the liver, cystadenoma carcinomas, can obstruct too. Hashtag outro.
Yeah, that was quite a journey through the biliary system. Really covered the spectrum, didn't we?
Yeah.
From its incredible variable anatomy and that complex physiological dance right through to, well, everything that can go wrong from a simple stone to really aggressive cancers.
Yeah, and if you think about the big picture, it really highlights how structure and function are just so tightly linked, doesn't it?
Absolutely.
That sole reliance on arterial blood supply, making the ducts vulnerable, the amazing efficiency of that enterohepatic recycling, the delicate hormonal balance with CCK and the sphincter, it's truly remarkable when it works.
So listening to all this, what stands out to you? Maybe it's just the body's resilience, or perhaps the incredible precision of the diagnostics and surgical techniques we have now to tackle these problems. It really shows how far medicine has come.
It does, and it leaves us with a thought, perhaps. Considering all those anatomical variations we talked about and the intricate physiological dance, what does it tell us about our body's capacity for adaptation? And also, its vulnerabilities when just one part of that complex system falters. Maybe thinking about these specifics helps us appreciate all that invisible work our bodies are doing constantly every single day, keeping things running smoothly, often without us even realizing it.